Hello and welcome to today's RettSyndrome.org RettEd webcast. This is Paige Nuez, Director of Family Empowerment at RettSyndrome.org, and importantly, mom to Katie, our beautiful 15-year-old high school student who also has Rett syndrome. On behalf of our Board of Directors and team, we're so pleased to bring you today's presentation on movement and motor issues in Rett syndrome, probably one of the most problematic and defining features for Rett syndrome. So if that's what you were expecting, then you know you are in the right place. Your children are really important to us. We believe in supporting you every day on our shared journey while we simultaneously and aggressively pursue research towards real treatments, interventions, and ultimately a cure for Rett syndrome. We invite you to please visit RettSyndrome.org to make sure you're signed up to receive all of our communications and to explore our website further for information regarding all research and family empowerment programs. We have a lot of information out there. We encourage you to be part of the change you want to see by participating in the RettEd webinars, such as today's, as well as in fundraising for RettSyndrome.org and participating in current and open research studies, such as the natural history study, the Cervical clinical drug trial targeting breathing issues in Rett syndrome, whose enrollment and age has now been approved for children 4 years and older who meet enrollment criteria, as well as the many other clinical research opportunities that are right here happening for our community. They're listed on our website. The RettEd webpage at rettsyndrome.org/RettEd is where you will also find our calendar of upcoming events in your community and future webinars. Registration is open for all of them, and you can also find links to prior RettEd webcasts and conference presentations. So before we begin, if this is your first time joining us, I want to share some brief technical points on how GoToWebinar operates. So, the audio feed is open only for our presenter, so you don't have to worry about your background noise interfering with the presentation. Always a good thing if you're at home or out in your community or at work. If you look to the upper right corner of your screen, you'll see a control panel window. We invite you to type your questions or comments in the question field throughout the presentation, and we will answer these at the end of the presentation, as well as any questions that were pre-submitted at the time that you registered for today's webinar. If we don't get to your question today, don't worry. We will work with Dr. Suter to get all write-in questions answered and posted into a QA document to our RettEd webpage once we get that completed. If the control panel window is distracting to you, you can minimize or move the window. Then you may expand it at any time if you wish to type in a question. Next point, important. This session is being recorded, and we will post a link of the recording along with any QA documents we produce to the RettEd webpage so you can listen again or share with others. If you're having trouble hearing, please check and turn up the volume on your phone or device. Now I would like to introduce today's speaker. Now I'd like to introduce today's speaker and fantastic presenter, Dr. Bernhard Suter. Dr. Suter is an assistant professor of pediatrics and neurology at Baylor College of Medicine and Texas Children's Hospital. He went to medical school in Bonn, Germany, and did his postdoctoral fellowship on brain development at Harvard before obtaining his residency training in neurology and pediatrics at Texas Children's Hospital. He's worked in the Bluebird Circle Rett Center for 5 years alongside Dr. Glaze, Dr. Newell, Dr. Motil, Judy Barish, indeed the entire Bluebird Circle Rett Center team. His interest lies in gait and movement disorders and Rett syndrome, and he's the lead investigator in the Baylor Gait study in Rett syndrome. Dr. Suter first presented on motor and movement disorders and Rett syndrome on a webcast for us in 2015, and we're so pleased to have him with us today to update and share his enriched and advanced work in this specialty area. So with this introduction, we welcome you, Dr. Suter. If you are ready, I will turn the screen over to you now, and you can begin your presentation.
Absolutely.
Okay, invitation.
Okay. All right.
Great. We're seeing your slides now, and you can move into slideshow view. And I will mute my phone until further needed.
Okay, perfect.
Okay, thanks, Dr. Suter.
All right, here we go. Well, Paige, thank you so much for having me on this webinar. Thanks for all the families and healthcare personnel for listening in. I'm Dr. Bernhard Suter, Assistant Professor at Baylor College of Medicine, Texas Children's Hospital, and I'm hoping to bring to you today an overview of movement disorders, the most common movement disorders in Rett syndrome. My goals are really to work out which movement disorders are frequent in Rett syndrome, whom you can talk to for these, and what the people that will help you with the movement disorders, what are they likely going to do? It as what treatments are out there. First of all, you're of course all readily aware that Rett syndrome is a progressive neurodevelopmental disorder with a wide spectrum of behavioral and motor abnormalities. It has a strong genetic basis. Mutations of the transcriptional regulator gene MECP2 underlie at least 90% of the classical form of Rett syndrome and are found in about 40% of atypical Rett. Rett syndrome was first really discovered / described by Andreas Rett in 1966, where he published data on 22 girls with progressive cerebral atrophy syndrome who had stereotyped hand movements, so very characteristic movements. Back then, dementia, alalia, gait apraxia, and a tendency towards epileptic attacks. The disorder is primarily sporadic in nature, and so it took a really long time until the genetic basis was discovered, almost 30 years later. So when you look at Rett syndrome is still diagnosed based on clinical consensus criteria, and key features amongst those are motor problems. These include predominantly stereotyped hand movements. These, amongst them, very frequently the hand wringing that Andreas Rett had initially recognized in his practice, and when he became alert to the disorder. Then gait disturbances are an important feature and are listed among the diagnostic criteria. So are dystonia and spasticity and scoliosis. Here you can see the Rett diagnostic criteria, the revised criteria from 2010 from Jeff Newell et al. And if you look at the bottom, the main 4 criteria are listed there, and 2 out of the 4 actually deal with movement disorders. And then even if you look at supportive criteria, 3 out of the 11 supportive criteria also still deal with movement disorders in Rett. So what are the key movement disorders in Rett syndrome then? And I would like to come back to one of the first studies that looked systematically at the frequency of movement disorders in Rett, which was done in 1990, actually here at Baylor. And they found in that study that all individuals with Rett in their population, it was about 30 some girls with Rett syndrome, all of them had stereotyped hand movements, wringing of the hands, clasping movements, etc., and all had gait disturbances. Very common were also dystonia, teeth grinding movements, bruxism, eye deviation episodes, which we term oculogyric crises, and Parkinsonism as a feature of their overall motor system. And I will discuss these as we go down further on in my talk. However, other common movement disorders such as myoclonus or chorea were only seldomly found. And this is just the table to show you that they basically looked at the percentage of how often an individual movement disorder occurred, and you can see that the stereotype movements and the gait disorder was on top of the list. The teeth grinding was very, very frequent. The oculogyric crises were there, and dystonia was found in about 60%. With regards of movement disorders in Rett, they also noted that it is important to know that movement disorders don't stay static. The picture of movements changes over time. And in general, the girls and boys that exist with Rett syndrome become more bradykinetic, sort of develop a Parkinsonian phenotype over time. Their movements tend to become slower, they take shorter steps, they become more rigid, and their facial expressions may become flatter, what we call hypomimia. Alongside that, over their lifespan, they develop spasticity, so going from initially being really low and almost floppy in their tone to developing stiffness, and alongside that, they develop scoliosis. In a much more recent study, Jenny Downs out of Australia looked at the progression of gross motor skills over lifetime, and they had 3 times as many patients, I believe about 99 patients from the Australian Rett syndrome database that they followed with and looked at with factor analysis. And they noticed that there were 2 types of gross motor skills: general gross motor skills that concern standing, walking, sidestepping, and much more complex gross motor skills, such as stepping over obstacles, walking on an incline, in that these 2 groups also progressed over time, in that the general skills actually showed a definite statistical mild to moderate decline with age. However, the more complex skill, maybe somewhat counterintuitively, only showed a trend of decline. So the ones where you would think that cognition factors majorly into it, they showed a trend of decline, whilst the general skills showed a definite decline with age. And then another big chapter in looking at movement in Rett syndrome is the natural history study that looked at genotypes, so mutation type, and its relation to motor skills. And they found in a paper out of 2014 that gait paralleled the overall clinical severity the closest. And they found that some specific mutations tended to do better with respect to motor compared to others in respect to ambulation, hand use, independent sitting, and possibly a later onset of stereotypes. Examples are that common mutations such as 133C, 255X, or 294X tended to have a somewhat milder motor phenotype, whilst others, such as large deletions, did have a had more significant motor problems. Now, it is really important to note that these are correlations that they found throughout analyzing over 1,000 girls with Rett syndrome and their genotype, and are observations that were derived on a population, and these findings do not necessarily correlate to, or let alone predict, an individual outcome for any individual with a certain mutation, because there are large there is a large spectrum of motor disorders for any given person. And also importantly, we do not yet understand why specific mutations tend to lead to a milder motor phenotype. So I would like to devote part of my presentation to defining common motor disorders, motor problems that occur in Rett syndrome. Amongst the motor disorders, I think one that features prominently is a feature called dystonia. Dystonia originates when you have an alteration in muscle tone in a fashion that produces spasms or spasm-like contractions. This occurs when both an agonist muscle contracts and at the same time its opposing muscle, the antagonist muscle, contracts as well. And these involuntary contractions are often prolonged and can often lead to unnatural appearing body positions. And I will show a picture of that just in a slide or two. And if they are intense enough, they can even cause what is called a dystonic tremor, tremoring of that extremity. It is important to note that these positions can also last not very long. They can at times even be taken on for just very brief periods of time, almost jerk-like, and can resemble abnormal posturing that could originate due to seizures. And we'll get to that differential diagnosis further on down. It is important to note that dystonia as a movement disorder phenomenon occurs with many medical conditions and may have multiple underlying causes, not just one. And therefore the treatment approaches are usually several that are being taken. Amongst them are multiple medications used, physical therapy, use of bracing, orthoses. All of them are being used at the same time to try to control dystonia. Here are examples, illustrated examples of what focal dystonias, so not generalized dystonias, can look like, and common ones that may even occur in Rett syndrome. On the top, you have a phenomenon called blepharospasm, where the eyes are really clenched and the whole face is a little bit scrunched up. And this posture looks unnatural and will be maintained for a longer while than you think is natural. Another dystonia would be cervical dystonia, where, for instance, the head is rotated and maybe deviated backward, something that is described by the term retrocollis, and is held in that position, and the person cannot get out of that position. Another very important focal dystonia is limb dystonia of the feet, where the ankle turns inward, the foot curves, and the toes flex. Unfortunately, I was not able to incorporate the videos of these same movements, so I apologize, and you just have to bear these sketches in mind as we go on discussing dystonia. It is very important when you encounter these dystonic movements in your child that you keep in mind that there are some other phenomena out there that can really mimic dystonia and can look very much like dystonia. There is the spasticity that is getting worse over time in individuals with Rett syndrome. Spasticity leads to more permanent increase in tone and is accompanied, and that's important, by overreactive reflexes, which would not necessarily be the case in dystonia. But spasticity also can lead to contractures at the joints, and then the limbs are held in an abnormal position that looks like a dystonic posture. Importantly, seizures can sometimes mimic dystonia. certainly can lead to, and dystonia can lead to phenomena that mimic seizures on the flip side as well. For instance, if dystonia leads to forced eye deviation, the oculogyric dystonia, and the child is seemingly not as interactive during the episode as you think the child is at baseline, you could mistake that for a seizure. Limb dystonia, such as the ankle dystonia we just discussed, can at times be difficult to tell apart from posturing with contractions that are produced by seizure phenomena. And then, especially in the younger children, but also later, posturing can occur due to some general irritation, such as irritation through gastrointestinal reflux, GERD, or in the younger individuals, the infants, toddlers, with a phenomenon called Sandifer syndrome. So you have to keep all of those in mind when you come to your doctor and describe these events, that depending on the presentation, these may need to be distinguished upon. I want to briefly talk about what generally can be done for dystonia. As I said, usually what ends up happening is that there are multiple treatment approaches that are being taken, and medication is only one of them. And with regards to medication, treatment for most forms of dystonia is actually a little bit unsatisfying and frustrating even, because benefit may be incomplete and may be accompanied by intolerable side effects for the medication. Treatment approach at large is the same for any type of etiology of dystonia. Some medications that are used, and I'm just throwing out examples of medications that are commonly used in dystonia, anticholinergic medication, trihexyphenidyl, or in the US known under the brand name Artane. As a side effect, for instance, Artane can lead to dry mouth, decreased concentration or memory, even confusion, and it can lead to GI, gastrointestinal tract problems, which is a hefty side effect for individuals with Rett syndrome specifically, because they already suffer very commonly from GI issues. Baclofen is at times used for dystonia, but also spasticity. Baclofen is maybe not quite as efficacious, but sometimes has some benefit with regards to the pain that can originate in dystonia, especially if it is generalized dystonia. But it's a medication that needs to be handled by a specialist and very careful, because rapid up and down titration can lead to severe problems. Then there is other medications such as benzodiazepines. Clonazepam has shown effectiveness, and there are dopamine depleting agents such as tetrabenazine, which is really at the very severe end of the spectrum, to be used only at the very severe end of the spectrum commonly. Again, what is spasticity? Spasticity that increases in general over the lifespan of an individual with Rett syndrome is a state of increased tone of a muscle. For instance, these individuals may develop spasticity of the legs, so-called spastic paraplegia, leading to legs that are stiff, feeling tight and rigid, but it's also accompanied by an exaggerated reflex of the knee jerk. Underlying spasticity is a loss of inhibition of the motor neurons. So it is basically, the origin is a neuronal origin of this phenomenon of spasticity. Now I want to come to another or the second really large group of motor disorders in Rett syndrome, and those are the famous motor stereotypes. Certainly bilateral hand washing are a hallmark of this syndrome. They're not unique to Rett syndrome, but pretty characteristic to Rett syndrome. In Rett syndrome, there is a large variety of other rhythmic movements that happen, and we'll go over them in just a minute. And it is important to note that the motor stereotypes can occur certainly in conjunction with loss of purposeful hand movements and the onset of regression, but they can at times also occur before or after this. Motor stereotypes in general are a very common motor phenomenon, even in the general population. Has been estimated that about 20% of children in the general population exhibit some type of common motor stereotypy. Those are tapping, hair twisting, nail biting, and doing that repetitively. Also body rocking and head banging occur in the general population. Some studies have quoted up to 25% of individuals doing this. And there seems to be a family history to them even. Age of onset in the general population is typically before 3 years old. 80% really develop them by age 2. And they disappear over time. The characteristics of motor stereotypies is that they occur again, like dystonia, involuntarily. They are semi-rhythmic here. They're patterned and repetitive, and they seem purposeless. But they are usually continuous, which contrasts them to mannerisms or tics. They can be classified academically as either simple movements, tapping, mouthing, clapping, or complex, where a whole sequence of different movements is always performed in the same way. The people have looked at, and by the way, I don't expect you to read this whole table. I'll just make a few points here. People have looked at the occurrence of stereotypies that are commonly found in Rett syndrome. And markedly, a study of Temudo et al. In 2007 listed a large variety of them and analyzed in 83 girls with confirmed Rett syndrome what the percentage of each motor stereotypy was. And they found that really common motor stereotypies were teeth grinding. Almost 90% of girls had repetitive teeth grinding, also called bruxism. The hand washing motions we already talked about were found in 76%, so in the large majority of girls. Hand mouthing movements were very common at 36%, as was tapping, hand tapping, mostly in the midline. But trunk rocking and shifting weight from one leg to another when standing repetitively was also found in a significant percentage. Here are some illustrations of these movements out of that same paper. You see Rett girls with a typical hand wringing, hand washing movements. You see the hand mouthing movements. And the hand mouthing is sometimes accompanied by this phenomenon of retrocollis, the holding your back, your head flexed back, which sort of overlaps with the dystonic holding your head in that position. What are treatments for these stereotypies? People have tried a whole lot of environmental manipulations to try to kind of dissuade individuals, not only in Rett syndrome, also in other disorders, from engaging in these stereotypical movements, and specifically in Rett, but also autism spectrum disorders, these environmental manipulations were found to have relatively limited impact on this repetitive behavior. And currently, there is no established pharmacology medication use for these motor stereotypes. A wide range of medications have been utilized, and the efficacy is generally inconsistent and certainly will not lead to complete success, generally speaking. Again, these medications are limited by potential for long-term adverse side effects. So medications that, for instance, have been used are certain antipsychotics, Risperdal, Seroquel, others, SSRIs, and again, clonazepam and an alpha adrenergic agonist called clonidine. Finally, I want to briefly give you one more bit of information about the Parkinsonism, the slowing of the movements and the rigidity that occurs over time in these individuals. So the Parkinsonism features increase with age, the bradykinesia, which is the slowness of the movements, the postural instability, tremor. There appears to be an underlying neurophysiologic, neuropathologic etiology to that, in that at least one study has demonstrated imaging features when they looked at PET scans, positron emission scans. They could demonstrate that there were perturbations in the dopamine systems, a mild reduction in fluorodopa uptake, and increased dopamine receptor binding that support that there is truly some form of Parkinsonism to be found in Rett syndrome, and it is not just a general unclassified phenomenon. Many Rett girls and boys, so Rett individuals really, as they progress, they may have quite functional gross motor function, and then as they get older, they may actually run into a phase where they are much less willing to engage in gross motor activity, or it appears that they are much less willing to do that. And there are some phenomena that I will describe now that may be contributing to this. There's the phenomenon that they develop ataxia, which describes really a lack of muscle control and coordination during voluntary movements. And it describes the inability to really generate a normal trajectory that cannot be attributed to weakness or interfering involuntary muscle activity otherwise. For instance, the failure of making that targeted movement cannot be due to other movements coming, so to say, in between, dystonic movements perturbing that movement. Ataxia is actually one of the earliest motor problems typically, and can lead to fear of falling when moving, standing, to a tendency to develop a posture of tilting backwards in that fear of otherwise falling forwards. And this ataxia then ultimately leads to restriction of efforts to walk. There is really no good treatment for this type of ataxia. You can try with therapies to overcome the non-targeted movement, as it were. For instance, occupational therapy and music therapy can improve manual sequences. And for walking, this can to some extent be overcome by guidance strategies. Use of a walker may also help out with it, of course, but there is no treatment for the cause of the ataxia. And then a very similar name is that of Apraxia or Dyspraxia. This is a phenomenon that describes the inability to plan and execute a movement sequence, and is very frequent in Rett syndrome. It affects really the control sequences, how and when which muscles are being moved, and will very strongly affect walking or reaching as well. It is characterized by the phenomenon that the more active thinking versus automatic action needs to happen, the more it becomes difficult for the person to initiate and execute that movement. And this is often manifested in intense so-called preparatory activity. So, for instance, the individuals with Rett syndrome may be standing and rocking back and forth, may increase their hand wringing, may stare very intently, maybe even hyperventilate, breathe very deeply before they actually do start to take a step. Lastly, I want to talk about another motor aspect in Rett syndrome, and that is gait. Gait, I believe, is of fundamental importance in Rett syndrome. The gait pattern is, there's no gait pattern that is uniquely characteristic to Rett syndrome, but and the gait pattern is variable, but has some common features. Even Andreas Rett, back in 1966, described short steps, sometimes shuffling, and walking with swaying movements and a broad base. Often over time, he described that they develop tiptoeing in up to 40%, and they developed a tendency to push back this retropulsion that we just talked about. Gait patterns naturally change over time, and but especially the initiation of walking seems to become more hesitating. I'll skip this slide. Here is just one illustration of a younger child with Rett syndrome, a 5-year-old girl with Rett syndrome that demonstrates sort of the standing and moving with a broad base and moving on her tiptoes and moving with toe walking. And notice how she also, while she is moving, is performing the hand wringing, which sort of falls into that preparatory activity, wringing the hands, potentially, as it were, helping out the general movement program. I will now move on to another part of the talk, which is whom should you really talk to? Who treats movement disorders in Rett syndrome? And here it is really important to note that it is, as there is such a variety of movement phenomena and such a variety of treatment approaches that need to happen potentially at the same time, it is of utmost importance that your child gets evaluated by a multidisciplinary team. You certainly want her or him to visit with a neurologist, preferably somebody with experience in movement disorders and or seizures, to discern whether it's just a movement disorders in quotation marks and or a seizure. You want to have them visit with a physical medicine specialist and physical and occupational therapists. You might even need to get them to an orthopedic surgeon, for instance, if scoliosis is really featuring prominently, and a GI specialist if there are concerns that reflux is exacerbating the movement disorders. And of course, you would go to a GI specialist if other issues are prominent, such as nutritional issues. What will these providers then potentially do? apart from listening to you in detail, if you bring in a video of the movements, they will look at the movement and at the movements, but they may need to do actually further testing to really discern: is it dystonia? Is it a seizure? Is it a certain type of stereotypy? And they might order EEG, potentially even a video EEG, to rule out seizures. So that's a brainwave study, right, for the neurons. Or sometimes they may even need to do electromyography, which is basically looking at the firing of the muscles in dystonia. And they might at times need to do an MRI of the brain, although this is less frequently necessary, to rule out that there is not additional structural damage to be found. The first step in any way could be that you record the videos of a movement event on a cell phone and bring it to the office visit, and then see whether the generalist feels that he would like to send your child to one of the above mentioned, one or several of the above mentioned specialists that deal with movement disorders. Briefly, I want to say that, again, interventions for motor problems are not restricted to medications. Physical therapy, occupational therapy take a very prominent role there. Bracing, casting, ankle-foot orthoses are prominently used. Surgeries are used, for instance, if the heel cord gets really, really tight due to dystonia, spasticity. Surgery is also sometimes indicated if the scoliosis gets really profound, so that a spinal fusion surgery becomes necessary. Sometimes if you have a targeted muscle group, so a group of muscles, not a generalized phenomenon, but a group of muscles, botulinum toxin injections can be helpful. These are frequently performed by trained physical medicine physicians. They help, for instance, with cervical dystonia, with the blepharospasm, the eye scrunching, also sometimes in ankle dystonia. And if all of these approaches, and especially the medication approaches, lead to somewhat intolerable side effects in some rare cases, stimulation of the brain can be performed specifically for dystonia, deep brain stimulation for a deep part of the brain. This is not yet by no means standard of care, and case studies are still not very prominent in the pediatric population, but it is maybe one future avenue for people who have suffered intense side effects of medications, and their movement disorders are worsening, specifically their dystonia is worsening. Here I wanted to show, for those parents that have not seen what orthoses look like, ankle-foot orthoses that are very frequently used in Rett syndrome, are little braces that help to hold the foot flat. They prevent contractures and maintain range of motion. And they're almost always used in conjunction with some sort of physical therapy. They're used in the earlier stages, with the earlier stages meaning that they're not already contractures that have formed that need surgical approaches to overcome them. Very important to note is that, especially in the past, there often has been somewhat bleak attitudes towards intervention with motor deterioration, because despite the need for repeat, even surgical intervention, there can be further decline in motor skills. And that has, in the past, led to people giving up on pushing for more therapies, and giving up on pushing their children to remain mobile. But I want to throw out there that there are several studies out there. For instance, a study out of the 1990s that reported that when this person looked at 23 girls with Rett syndrome, for instance, 4 girls who had completely lost independent walking regained this ability with therapy. And 1 girl had learned transitions 3 years after not being able to do any sort of transition. And Hanks et al. Actually concluded that ambulation is a so moving out and about is a realistic therapy goal for most girls, especially in the early years, and should be very much encouraged for physiological and psychological benefits and to prevent downstream ill effects such as the formation of deformities, hip flexion contractures, increase in scoliosis. And one study that I feel is really, by the nature of the study, phenomenal, one study from 2001, Larson and Engerstrom had a small cohort of girls, and I should rather say women with Rett syndrome, who sort of had given up and become immobile and were sitting there and not walking despite having walked in their early days, right? And Larson and Engerstrom reported a case that with intensive physical therapy, a woman with classical Rett syndrome who had been confined to a wheelchair for many years was retrained to achieve standing by age 36 and then walking and transitioning by age 40. And I find that a phenomenal demonstration that it is absolutely indicated to not be defeated by the general course of the disorder and to push for ongoing physical therapy and ambulation. And ambulation in general it has been demonstrated before that ambulation in general can be a very beneficial means to further general fitness in Rett girls. A study out of Israel they showed in 2004 that when they subjected the 4 Rett girls with a mean age of 10 years to undergoing a treadmill training protocol, and they tested functional motor items pre and post, before and after the 2-month training, they found that physical fitness and functional abilities of the children had improved considerably. So maintaining ambulation and training ambulation seems to have an overall very important effect on general health in Rett syndrome. I very briefly want to finally mention what is being done in ongoing clinical research in motor and gait disorders in Rett. People are using questionnaires, different questionnaires, such as the motor behavior assay, the gross motor scale, the Rett syndrome behavioral questionnaire in scientific studies to try to capture these various movement disorders. For instance, if your child is enrolled in the NIH Natural History Study, movement disorders would be captured amongst others via the motor behavior assay. There are studies that utilize video assessments and or activity trackers. And then especially here, I'm lucky enough that I can perform the gait analysis in a professional gait lab to examine gait problems further in Rett syndrome. And there are also some basic science researchers that look at mouse models of the disease where the mice's genes are altered just as in the human disorder, and they can even look in vivo into the brain and using novel microscopy techniques and fluorescent dyes, and they can learn about changes in brain circuits with a hope that possibly alter these circuits downstream. Here is an example how the setup that by now has improved, but used to look about 3 years ago. I want you to note that this individual who is a caregiver, not a girl with Rett syndrome, but is representing a girl with Rett syndrome. She wears several markers on her body, reflective markers that are then videoed by very specialized cameras that stand all around her while the treadmill basically is set in motion, and the person will then walk and the gait analyzed. And we just right now are coming out with a paper from this gait study where we have demonstrated that there are changes when you look at Rett girls walking on a treadmill versus just spontaneously over ground, that certain phases of the gait improve, the swing time is shortened, the double support time is shortened, and very importantly, overall, treadmill gait resulted in decreased variability, so a more regularized, maybe more quote unquote normal gait. And we're hoping to go on with this study in the direction of trying to come up with an interventional protocol measuring improvements with treadmill training, but that is still a thing for the future. I'm skipping the selected references. You will get those in the handout. And I want to close my PowerPoint presentation with a big thank you to you all listening in, to all the wonderful, wonderful families that I've come in contact with, that have allowed me to care for their children and that make the research possible. A big thank you to all my mentors, markedly Dr. Glaze, Dr. Newell, also Dr. Zogby, of course, and a big thank you here in Houston to the Bluebird Circle, who has funded part of the research endeavors. And with that, I finish my presentation, and I will click on the button for stop showing the screen and hope that Paige will take over.
You could do that, or Dr. Suter, if you would like to leave your slides up, you may want to refer back to a slide as we go through the questions that have been submitted by our attendees.
Okay.
If that would be okay?
Okay, absolutely, yes.
Okay, and who doesn't love to look at this beautiful group?
Haha, true.
Okay, that's a good resting slide. All right, well, thank you for all of that information. I hope you have a drink of water nearby and can take a breath. And we have about a dozen questions that have been submitted by our attendees, and the plan for this webcast is that we will go 90 minutes, so that will give us about a half hour. Hopefully we can get through all of these questions. Many of them you addressed in your presentation, but because they are of real concern to the families that are online right now, perhaps they serve to, revisit and highlight some of the information you presented. Okay?
Mm-hmm.
Okay. So the first one, and this is a beginning question, but I think it's a really good recap after you presented so much good vocabulary and good information, is after this presentation, if a parent still has a question of whether their child is really experiencing dystonia, what should they do to really know that it's dystonia versus spasticity?
Versus any of the other movement disorders, and potentially versus seizure-like movements. I think really what is critical is to try to capture these dystonic movements potentially at home, if at all possible, on a little video with a cell phone. Important there is to not only focus in to the affected region, but doing that and in addition also zooming out so that the whole person is being captured, at least briefly, during that movement. And then when the care provider parent has that, I would advise to really meet with a specialist who deals routinely with movement disorders, such as a neurologist who deals with movement disorders. Sometimes even a general neurologist has sufficient expertise there. A physical medicine specialist can be very, very helpful in evaluating these movements that are suspicious for dystonia. And at times they're very difficult to tease out, and they might need to undergo testing, as I said. Electromyography or an EEG may become indicated, but that is not usually the case. Usually a healthcare provider that has expertise in movement disorders will, in the larger majority of the cases, be able to tell you what the movement is about.
Thank you. And can I ask if they are still left with questions and are really looking for a Rett syndrome expert, that if they could get the referral to the Bluebird Center, that they could come for an evaluation and assessment with you?
Of course, absolutely. And that is also the case for other Rett centers that see a large that see Rett girls, the largest proportion of which have some motor issues. Yeah. Mm-hmm.
Thank you. Okay, I'm going to move to the next question, which is a very big question for all parents who have nonverbal children and with communication impairment, is our concern with pain.
Yeah.
Can you talk a little bit about the connection of dystonia and pain? A particular parent is concerned that the dystonia is causing severe leg pain for her daughter.
Yeah. And that is a very valid concern, because certainly being stuck in a position sort of akin really like a muscle cramp, only more prolonged, is can produce pain, right? And so in a sense, the dystonia as a side effect can produce pain. It doesn't always lead to pain, but if the dystonic position, where both the agonist muscle and then its opposing muscle sort of fight each other and cramp up the extremity, like the legs, right, can become very, very uncomfortable. Medication can be used to treat dystonia that has some effect on the pain itself. I had mentioned that in sometimes baclofen seems to have some degree of effect with regards to pain, but really, unfortunately, none of the medications that treat dystonia are perfect for pain. It is not usually the case that they alleviate pain completely. So it is what is necessary is really then a very cautious fine-tuning of these medications with the specialist to see how high one can go up in treating the dystonia medically without causing severe side effects that preclude further medical treatment.
Okay.
That would be my my primary answer to this question. Certainly, if the dystonia were to be almost completely controlled, I would expect that the pain also is relieved. So the primary target will very likely be the dystonia and not the pain management. The pain management will be taken into consideration, but the dystonia management will be at the very forefront, because if the dystonia is gone, then the pain may very well decline.
Okay. And is this a different approach than pain that might be resulting from spasticity and contractures?
The mechanism is a little bit different in that, but for all extents and purposes, not that different. And for instance, baclofen is very prominent in the treatment of spasticity. So again, it's being used in dystonia, it's being used in spasticity. Speaking to that, very often similar approaches are being taken to address these issues. And there is not a one-to-one, I have this type, very specific type of dystonia, and that warrants medication A versus a different type of dystonia, and that clearly warrants medication Z.
Okay, thank you. Next question. My daughter has dystonia, and when I stand her up, it stops. Her physical therapist tells me, though, that I shouldn't move her, but she reports much longer episodes than the parent sees. So is it okay to stand her up and disrupt that dystonic episode?
I apologize. I got interrupted because of an intervening Outlook message. Now I killed Outlook. Could you just please refer the standing question again?
Sure. Okay, so parent asks, my daughter has dystonia, and I stand her up, it stops. But her physical therapist tells me I shouldn't move her, and her physical therapist reports much longer episodes than the parent sees. So what are your thoughts? Is it okay to stand her up to disrupt the dystonic episode?
So sometimes dystonic events can be provoked by certain muscle activity and certain muscle movements. They can be brought out by certain movements, and standing could feasibly be one of those. But I am not quite sure why the physical therapist in that case would disadvise against standing if the individual is able to stand at baseline. That is not a situation that I would be able to fathom without knowing the individual personally. It is sometimes disadvised, again, to engage too much into certain movements that bring out dystonic posturing. If you can think of it this way, the following way. One frequent form of dystonia, a relatively frequent form in the general population, is writer's cramps, right? And the more you intensify your grip and the position, the worser you make your writer's cramp. So you have to have a very cautious approach to writing in that case, depending on the severity, obviously, of the writer's cramp. And this is maybe a similar situation is underlying in the person that is asking this question, in that the therapist has some degree of concern about frequent standing and bringing out this dystonic episode. But again, without further description and without seeing the person personally, I do not have any more specific advice there. Paige? Hello?
Sorry, I was on mute. Sorry about that. Thank you very much. That was a good, it was actually a very good response to the question. Thank you, Dr. Suter. Okay, next question is regarding dystonia and stereotypes. I think this is regarding upper limb stereotypes. Yeah. Do you believe that they contribute to the progression of scoliosis? And do you know if there's any evidence on mechanically preventing stereotypes, such as using elbow braces, in the prevention of scoliosis?
specifically for scoliosis. So scoliosis is more thought of as a separate entity, and certainly not a stereotypy, and also not really, well, it may fall more in the domain of dystonia, but I think, and spasticity, that is. But I think the question was also targeting a little bit whether if one tries to get stereotypes under control, if one were to achieve that, whether that has any influence on the development or worsening of scoliosis. And I'm not aware of that. I do not think that the stereotypes interfere in a good or bad way with the formation of scoliosis. Scoliosis is a very long-term development, and I don't think is influenced by the stereotypes that occur. And in part, I take that from thinking about motor stereotypes in the general population, which, as I had said, are very, very frequent, with up to 20% of the general population having frequent motor stereotypes, and really not developing any long-term side effects as far as we know from that, if they're simple stereotypes. In terms of efficaciousness of intervention with bracing, splinting, typically elbow splinting, for instance, is more done to restrain the harmful effect of these repetitive movements in terms of causing callus formation or abrasions, and do not typically, as it were, re-educate or redirect a Rett individual to not have the stereotypes. In fact, what I personally encounter in my clinic is that parents tell me over and over again that if they take off the brace, that the Rett girl or Rett boy just continues as if nothing had happened, as if the elbow splint had never been worn. Does this address a little bit the question you feel, Paige?
I think so. And in fact, it transitioned well into covering a few other questions that some folks had about the use of elbow splints and intervention, decreasing stereotypes. As parents, I also have experience with my own daughter, and have had many parents comment, though, that the use of the elbow splints does seem to calm her. Even if it is not used, even if it's not beneficial for re-educating or decreasing stereotypes over time, that during the time in the elbow brace, she seems to be calmer and more able to focus on other activities. So in addition to using them to prevent skin breakdown, calluses, hand-mouthing behaviors that are, do you also find that there's other benefits?
Yeah, thank you, Paige. That is a very good addition to the comment. It is absolutely the case that stereotypes can interfere on multiple levels with other activities, and I can absolutely see it that if you, so to say, control the stereotypes, that that other activities may become possible, that that your daughter and others with Rett syndrome might otherwise not engage in, because of the continuous ongoing stereotypes. And there may be a cognitive part to it. There may be simply a motor part to it. I do agree that that some parents report that while the individual is wearing the brace that she or he is calmer.
Okay. Following in this thread, we have a very good question from an OT who has worked with several women with Rett syndrome, and she's curious to know if there has been any research to connect the visual cortex with stereotypes, because what she has found in her clinical practice is that on working with her children, if she just takes a lightweight towel, and puts it over the clasped hands of her client or patient, blocking out the visual
connection
that she seems to calm down, or they, I should say, because she treats multiple women and has found this effective. So have you experienced that, or are aware of any connection?
So no, my frank answer is no, and I would need to look into this. I think predominantly the thought is that motor stereotypes are really involuntary and not involve a whole lot of active cognition, but that is a very intriguing observation, and I myself will have to look into it. I've not come across literature for that to be the case, and I have not had that mentioned in my practice before.
Okay, thank you. Next question in the queue is regarding cervical dystonia, and what is a common type of brace or intervention for cervical dystonia that you might use or recommend?
So, I would have, for the specific type of brace, I would probably have to defer to a physical medicine specialist, because I don't traditionally, as a neurologist, prescribe the braces. I think that there, again, you would start with typically with medicines, with medical treatment, and sometimes what has been beneficial for this cervical dystonia is also Botox injections for cervical dystonia. Brace-wise, I do unfortunately not have a specific recommendation for you. Again, this would be probably better answered by a physical medicine specialist and not me.
Okay, thank you. And we will have a a physiatrist as a future speaker on a webcast. So we will hold that question until that time, and we can if that attendee would like further information, just go ahead and email me at pnuez@rettsyndrome.org, and I can connect you with a specialist sooner. Okay, next question. Okay, this is a parent of an older child, and it's really addressing what you discussed about balancing intervention through medication versus some of the really difficult side effects of medication. Yeah. Her daughter's 20 years old, and she has really bad dystonia. She is on artane, diazepam, propanolol chloride, if I'm pronouncing that correct, clonazepam, and clonazepam. Now, due to the artane, she is experiencing problems with urination. She needs a catheter and swollen cheeks and face. And she's just curious if there's any new medications on the horizon or in existence to help with the dystonia, so she wouldn't have to suffer these side effects of urine retention and swelling.
Yeah. I need so the artane is the very likely culprit for these urination issues. It is also in the group of medicines that are being used for dystonia, one of the most effective ones, and therefore frequently used, right? I am not familiar that there's specifically in that situation that there would be a new medication out there. It sounds like her daughter is on other medication that also plays into dystonia treatment and supports dystonia treatment. Short of really knowing your daughter, I would hesitate to give concrete treatment advice. In a nutshell, there is not, generally spoken, a medication out there that does not come with side effects in dystonia treatment. Almost all of the medications do have side effects. Certainly some of the less problematic ones would be benzodiazepines, but she already is on clonazepam. And I am not sure that a medication that is reserved for the very severe generalized dystonic state, such as tetrabenazine, is indicated in her daughter. So I think in order to fairly answer this is that I do not know about any new medications that exist that help with dystonia when you have a lot of side effects from the artane. It may be possible that additional strategies to medication use may be of benefit, but I'm not sure what specific type of dystonia this individual has. But sometimes one can think about interventions such as Botox, or in very extreme cases, brain stimulation. But again, I'm not sure what type of dystonia this individual has.
Okay. Thank you.
Mm-hmm.
I know that it's difficult to provide an answer for a child that you haven't seen yourself.
Mm-hmm.
Okay, so there's another question, and I think this is referring to the research where you demonstrated that work on the treadmill showed better improvement than intensive just walking over land. So I'm going to combine two questions so that you can answer them at once. One is, for that research, do you feel that it was the use of the what's it called? I'm sorry. When you're on the for the harness, that the harness could have made the participants feel much more secure, so that that experience of walking in the treadmill was more beneficial. Also, a related question is a parent who's currently experiencing that their child is tending to bend over and tilt more forward as she's walking, so she's using a gait belt to help. And I'm thinking a gait belt may also provide that sense of security and motion, as well as the use of the harness on the treadmill. Do you think that it's that input that is showing the efficacy?
So for sure, it is known that sensory feedback of various types will support ambulation, meaning walking in girls and boys, in individuals, I should rather say, with Rett syndrome, from very mild, just sensory stimuli such as touching at the elbow and guiding, to really having some physical mean of support, will improve likely pretty much all aspects of gait, right? For our study specifically, we did not feel that our harness here provided very much of a feedback at all. It was not very tightly fitted. It was just there to protect in case of if the patient stumbled or dropped. We kept it on purpose, in so to say, out of the way. Now, whether the Rett individual, any given Rett individual that we studied, was cognitively aware that they had that as a protective mechanism should they stumble, that I cannot exclude. But we certainly did not fit the harness tight enough or to provide significant sensory feedback, nor, let alone, there are some gait training protocols that actually relieve the person of weight to some degree that have shown benefit, for instance, in children with cerebral palsy and gait training on the treadmill. This is not the direction that we have chosen for our analysis. So, had chosen for our analysis. So we at least hope that, if at all, it is a very minimal feedback that we have provided these individuals on the treadmill. But to answer the second question is that, for sure, any type of sensory support tends to help with overground gait quite a bit in the Rett girls.
Okay. Thank you. That was a very thorough answer, and I really appreciated your concluding slides that showed women in their advanced years who have, for some reason, been wheelchair bound or stopped walking, that with intensive therapy regained those skills, and some of the data that showed that many girls, especially younger age, can achieve ambulation, and perhaps it is, a therapy that's really attending to that sensory input and intensively at the beginning, and then eventually fades away. Is that continuum to achieve success at any age.
Yep, and I think ultimately the best intervention is probably, as you maybe partly pointing out, that is an integrative approach where you have some, physical training in it, aided by sensory feedback, and also what they did in the 2001 paper is that they had sort of a cognitive component in there where they clued the individuals into a situation where that woman had been walking as a child to make it possible to, simply speaking, in a simplified manner, remembering the environment and the motions that she had been going through that may have contributed to those successes.
Okay, we're approaching about the last 5 minutes of our presentation today, and I have 3 more questions if we can get through. One is interesting, and I haven't thought of this before. Do you think that dystonia is a contributing factor to constipation in our children with Rett syndrome, affecting their ability to have a bowel movement, that perhaps the sphincter muscle is affected by dystonia?
Okay. In general, I could definitely see that the dystonia has an impact on the GI system, albeit maybe indirectly through forcing the individual to have body positions that are not conducive to gut motility, and probably you can, even though I have not myself thought about this or come across it specifically, you can probably have dystonia in any voluntarily innervated muscle. So it is possible that that some degree of the sphincter area is affected by dystonia. It's not something that commonly is being described. I would bet that in those cases there are more parts of the body affected by the dystonia that also contribute to GI upset and potentially the smooth passage of nutrition through the gut system. So absolutely, I can see that dystonia could have, especially if generalized across many body parts, could lead to positions and that influence to some degree the functional mobility of the gut system. I don't think that dystonia itself occurs within the gut, though.
Okay, thank you. It's an interesting question, and one we'll think about moving forward. I want to bring up the last two questions that are related, and I think it's a really good question that we end almost every webcast on. And this is going to cause you to think. Parents who are asking for strategies to help their practitioner listen to them. So sometimes they're feeling like even if they take these webinars and share them with the school or a therapist, that they stay firm on their intervention, even if our expert opinion is showing otherwise. And the related question is a parent who is getting 3 different recommendations on the types of AFOs for her daughter to wear, and she doesn't know who to believe and how to go about differentiating the right one. So because we're getting to the end of time, I'm going to, ask you to layer in those questions. So, for example, this the PT wants her child to wear calf-length AFOs. The orthopedic surgeon wants ankle SM AFOs, and the podiatrist recommended just a shoe insert. How's a parent to know who to trust for their child's care, and also if they're not confident that the practitioner is really listening to them and taking advantage of this kind of information that you've presented today, what are some strategies that they should do?
I think, those are 2 hefty questions, and you're right, they send me thinking. I think there are, though, probably questions, unfortunately, that are not unique to Rett syndrome itself, right? The latter question is actually more difficult to answer, because if there are different healthcare professionals who each believe in their approach of treating a certain problem, well, that's the way they have been trained to treat this phenomenon, right? Healthcare phenomenon. And maybe then it is truly up to the caregiver to reach out, see whether there is, assuming that all of these interventions are interventions that fall under standard of care, right? And none of them are really wildly out there. That the parent can reach out to the community via rettsyndrome.org or whatever, to see whether other individuals have come across similar problems and how they have tackled this individual problem, right? Which is the right type of AFO / SMO / inlay, etc. And or they could, of course, if they're not located at one of the Rett centers, they could look for a second opinion from from a physical medicine specialist at one of the Rett centers, because presumably that physician is fairly clued in to Rett syndrome and a certain approach for that problem. I hope that is really the way that if as a parent probably I would go about if I felt that any of the interventions are fairly equivalent and that one of them doesn't just fall by the wayside by its exaggeratedness. I would probably myself try to reach out to the community and or try to get a second opinion at a Rett center for what to do. And regarding Paige, remind me again, the first part of the question was aimed at how to convince providers in the larger world out there, school providers at school, in the schooling system, for instance, to follow along recommendations that parents have heard about in webcasts such as this one, right? I think that one approach would be to actually direct, especially at the school. Some schools are very open to get in contact or be contacted by a person from one of our Rett centers, providing some professional feedback on how to address specific situations in Rett syndrome. So it may be an avenue. I know in our Rett center, Judy Barish, our nurse, used to for many years educate schools about Rett syndrome. It may be that reaching out to such an individual at a Rett center is of benefit to convince the schooling system to go through with a certain treatment recommendation. Paige, are you still there?
Oh gosh, I did it again. I was talking on mute. Thank you, Dr. Suter. That was an excellent answer. And what I was saying is that is exactly the advice that I often give families. If they don't feel that they are getting accurate, correct support from their community providers, if possible, take your child, be followed at a Rett center. Rett experts are all wonderful. Dr. Suter, you're an exemplary representative of our clinician community who every day become advocates for our children. So if your providers are not listening to you as a parent, try to get somebody with a higher credential to come in and advocate for you. That can often sometimes work, and it takes time, but our kids require us to be their advocates. And I think that is a very good note to end on. One of hope, one of advocacy, one of continued research and effort on all of our behalves to help our children and adults continue to grow and thrive and be as healthy and as well as they can be. So on that note, Dr. Suter, I would really like to thank you for your presentation. I know you have an extremely busy clinic schedule, and it took a lot for you to take this much time out of your day and prepare these slides, but you have been an incredible resource. So thank you.
All right.
Okay. You give us hope, and we just wish you well with all of your continued research. And thank you for such wonderful care and compassionate care of our kids.
Thank you.
So,
the questions coming.
I will. And if any questions come in after the session, I'll be sure to communicate with them with you. We'll get a QA document prepared, and we'll post it to our website with a link to today's recording. And for all of our attendees, thank you for sticking with us. We hope you found value out of all of today's information, and we hope that we will see you next month on July 10th for our next topic, which is also an incredibly important topic for our children, which is around communication and making it count, with our guest speaker, AAC and OT expert, Judy LaRiviere from Katie's Clinic for Rett and Related Disorders at UCSF. So go to our website, sign up for next month. Also, within a day or two, you will see email in your inbox with a link to today's recording. And we encourage you to share it with all of your practitioners. They can fast forward to the specific part that is relevant to you and your situation. And any further questions that you have, send them to me. I'll work with Dr. Suter to get answers out for you if possible. Thank you so much, and now this concludes our RettEd webcast for today. Thank you, and we'll see you next month.